Memorial yesterday we discussed something like the angioedema, something like the FMF. So you will miss the full case, and this is what we never wanted to happen during our exam. So I need you at least to have an idea. Don't spend much time on studying PAN instead of studying systemic sclerosis, for example. But you still need to have an idea about it. So I'll not spend much time with that, but at least you need to know what is the polyarteritis nodosa and what are the symptoms, and they'll make it very simple, inshallah, for you. Simply for the patient with PAN, because we will not practice this case, but the details of this case, it was a patient who was complaining of 1 month history of abdominal pain and weight loss and dark stool. Okay, on examination, he had soft and tender abdomen. Okay, this patient has the blood works with the patient showed, just a second, please. The blood works with the patient showed that elevated kidney function and it's with liver function, and the patient is a barber, and he didn't tell you in this case that he has hepatitis B. Okay, then the symptoms the patient have elevated pilaris, as you see in this picture, and eventually this case will come as PAN, polyarteritis nodosa, and here in the polyarteritis nodosa you need to ask about any known liver disease like hepatitis B or sign and symptoms of liver disease, as we said in the first lecture, how to ask about the liver disease. So again, I'm going fast through the PAN because it's not very important, but I will give you an idea about it. The symptoms of it will be just constitutional symptoms like fever, malaise, anorexia, weight loss, and arthralgia. There will be CNS symptoms up to blindness, up to seizures. There will be peripheral nervous system symptoms like peripheral neuropathy. There will be skin symptoms like rash, purpura, libido reticularity, digital ischemia, and answers. It is important. Testicular pain. In this case, I will give you testicular pain. Okay, if you ask about that. Okay, abdominal pain and hypertension and renal failure. Just to remember it, to make it a little bit simple for you. Okay, it is PAN, polyarteritis nodosa. So just remember the P refers to pain. Okay, and here which type of pain? I want you to write that PAN. Write this letter. This is the most important slide for PAN. The P for pain. Okay, and the pain here I mean testicular pain, abdominal pain, and joints and muscle pain. So try to write that. I'll send you the slide. Try to write what type of pain. Okay, so testicular pain, joints and muscle pain, and abdominal pain. Then positive ANCA, not B ANCA mainly, but I mean positive ANCA, anti-nuclear cytoplasmic antibody. Then pressure, the blood pressure will be high with these patients. Okay. Then the other B is 2B, not P, bleeding. Patient may come with bleeding, with the rectal bleeding, and then hepatitis B. Okay, so these are the P and Bs. Okay. The other thing, there is always kidney affection. So when they do the arteriography, it became positive for the vasculitis. It come back positive with the vasculitis for the PAN. Okay. Something I want you to write about the PAN, it is vasculitis affecting the small and middle blood vessels, and it is very rare to affecting the pulmonary. So most of our vasculitis that we know, like Wegener, like most of the vasculitis we will discuss in the coming lectures, they are affecting the kidney and affecting the lung, but PAN usually spare the lung. It's affecting the renal arteries and affecting the mesenteric arteries. So remember, there will be renal impairment, and there will be also maybe bleeding, rectal bleeding, or ischemia. Okay, so for the P's, as I said, pain, remember testicular, joints, intestinal, then P ANCA, then high blood pressure, then bleeding, then B hepatitis. Then the A for anemia and arteriography will come positive. The A refers for the positive arteriography. There will be microaneurysm in the angiography. Yeah, you will not find this slide. This slide I will send to you. Okay. So P ANCA, as we said, the angiography will show the renal microaneurysm angiography. Then the N for neurological symptom, as I said, blindness and maybe seizures, maybe TIA, stroke symptoms, and there will be neuralgia. This is more than enough for the PAN. What you need to do, you do arterial biopsy. You need to do general lab works, including hepatitis B, but you'll do CBC, CRB, ESR, P ANCA. It's positive for, rare for P ANCA to be positive, but it is there. And then the biopsy. And the treatment for PAN is steroid. Okay, and if there is no hepatitis B, they give cyclophosphamide with the steroids. They will give cyclophosphamide with the steroids. So here you see this slide, weight loss. I will send you this slide, don't worry. So weight loss, rash, testicular pain, myalgia, neuropathy, high blood pressure, hepatitis B, okay, the arteriogram, aneurysm, and high blood urea. So these are the investigation and these are the treatment. You receive these slides, don't worry about this one, okay? So this was for the PAN, for the abdominal pain, because we are done with the abdominal pain last time. So I will go now to the next presentation and we will start our first case. Just give me a second. Okay. So now this is the first case. So I need Dr. Now I will close the chat. So no distraction by answering the questions. So I need that chat will be for me only. So please, Dr. Amr, if you can hear me, Dr. Amr Amin, send to me that the voice is clear now. And for Dr. Muhammad Muzhir al-Islam, or I hope I'm pronouncing the name correct way. So please confirm that the voice is clear. Is it clear now, Dr. Amr? Okay. So now you can all chat with me only, and I'll close the mic. So you'll not be able to open your mic. I will just open the mic of the doctor will practice. Dr. Abdullah Saeed, are you there? Dr. Abdullah Saeed, are you there? Dr. Abdullah, where are you? Do you appear as Abdullah and two dash? Hello? Dr. Abdullah, I have two Dr. Abdullah on the list. Confirm that this is you, Dr. Abdullah. If you appear as iPhone 2 and you are going to be the next case, are you there, Dr. Fawzi Maqlid?
You hear me? Yes, I'm Dr. Fawzi, yes. You hear me, Dr. Muhammad?
Yeah, I hear you, Dr. Fawzi. As station 5 also. So if the case appears as station 5 in the exam, you'll be able to know what to examine, because both cases can come, the case can come in both forms, can be station 5 or can be history, okay? So this is a patient with, sorry, this is the wrong age. I'm sorry, just a second. This is 34, sorry. Okay, so this is Mrs. Ghada Halim, and she is 34 years old. And this 34 years old lady is referred by her GP for severe chest pain and awareness of heartbeat. She's not on any medication other than ibuprofen for her joints pain. She noticed that her chest symptoms increased and become more frequent recently. Please, for your kind care. Okay, this is her vital signs. So you have, in the exam, you have 5 minutes. Now you have 2 minutes to take a look and put your plan. Okay.
Okay.
As I said before, for everyone, please write in blank paper what you are going to do. Dr. Fauzi, I remind you, did you attend the first lecture, Dr. Fauzi?
Yeah, sure.
Okay, great. So remember the structure of the case. So remember the family history, remember the social, remember all the details, please. Okay, and remember to summarize. Okay?
Okay, Dr. Muhammad.
For everyone, please watch your differential. Stand, do some dumbbells. Don't take it as a lecture, just take it like it's just a study, okay? Can you start, doctor?
Okay, Dr. Muhammad.
Okay, so start. Okay, go ahead.
Hello.
Hello, doctor.
I'm Dr. Fauzi from Medical Unit on Call today. It's a recorded clinic. Sorry. You are Mrs. Rada?
Yes, doctor.
Rada Halim. You are age 64 years old age.
Yes.
Yeah, how are you?
I'm good.
Fine to meet you.
Thank you.
Okay. Mrs. Rada, please tell me why you are here today. Your GP referred you to me for more details about your condition, chest pain like this. Can you tell me more about this?
Yes, doctor. I'm suffering of chest pain, and I had these attacks of chest pain before, and it was not the same as now. Actually, usually I feel that there's a tightness of my chest, but at that time I thought it was related to stresses because when I cry, this pain will leave usually, and I'm under very heavy stresses these days because I was divorced. The problem, doctor, that recently in the last 2 days, this chest pain is persistent. It's all the day, and it become more severe. And I'm feeling my heart like it's racing. It's going to jump out of my chest. So I'm very worried about that, doctor, and I want to see what's going on.
Okay, we'll help you try to solve this problem. But I need to clarify something. You told me there is a long-standing chest pain. When did it started, please?
In the last 1 year, doctor, or 9 months, because I had a lot of troubles with my previous husband, and I was in stress all the time. So all the time I feel heaviness on my chest. But as I told you, I went to the doctor twice, and they made for me the heart racing and everything, and they told me that everything is okay for now, and they told me that it may be related to stress. That's it. But this time it's different, doctor, and it is more severe, and it never relieved even with rest or even without stresses.
Okay, Mrs. And please can inform me also about this pain, nature of the pain. I mean, is pain is the compressing pain in nature or stabbing or like?
Yeah, doctor. This one now, I feel like there's a tear on my chest. It's like there's a knife going in my chest.
This is pain is all over the time or?
Yes, in the last 2 days, yes, it is all over the time, doctor.
Yes, okay, sorry for that. So this been started 9 months now until now is but progressively increasing. Is right?
No, doctor. I told you that I have a chest pain that was coming on and off in the last 9 months, and since the last 2 days there is a chest pain, but it's a little different to the previous chest pain I have.
The previous chest pain is what is the character of this pain? I mean,
it's like heaviness. I feel like heaviness. I feel that I can't breathe well. But as I told you, it's relieved usually when I cry and become more quiet.
Okay, and you are asthmatic?
What?
You take any inhalers? You before inhalers before?
No.
Okay, and this chest pain is associated with any symptoms like sweating, racing with the heart, like this?
As I told you, doctor, I have heart racing.
Yes, and this associated with this chest pain or came with,
yes, doctor. Yes, it is in the last 2 days also. It's become persistent all the day. I feel my heart.
Yes, and this been increased with effort?
I can't do any effort, doctor. Anyway, whenever I do any effort, I feel shortness of breath. In the last 2 days, I can difficultly walk. I'm hardly walking.
Sorry for that. And this being referred to any other area like hand or shoulder or back?
I feel that in my chest mainly, doctor. Maybe it referred a little bit to the back, but it's still in my chest mainly.
Okay. And this is continuous last 3 days? Continuous
2 days, doctor. 2 days.
Yeah. Okay. Sorry for that. And this chest pain is sometimes occurs with sudden onset of difficulty of breathing, like shortness of breathing, or all over the time is without problem with breathing?
I told you, doctor, in the last 2 days, I'm short of breath.
Okay. Sorry for that. Please, can you inform me more about heart rate? You should say this racing heart rate. Is this heart rate is regular or irregular?
I think it's regular.
Regular, yes. Okay. And there is any fever?
Fever?
High temperature? High temperature? Is there any high temperature?
In the last 2 days, I feel a little bit that my temperature. They told me even when I came now, the nurse told me that I have a little increase in my body temperature.
Is the exact number of temperature scale?
Look to the patient vitals on the sheet.
Okay, sorry, yes. That's the case. Is this being relieved by leaning forward or by position?
No, doctor.
No relation. Okay. Yes. Okay. Let me know about your always like blood pressure, like here as the GB sent to me is 107. You have breakfast feeding. You know about this?
Breakfast feeding? I don't know, doctor. I'm not a doctor.
Breakfast. Yeah, I know, but before is when you frequently visit the GB, he told you about the blood pressure.
I don't have a high blood pressure.
Okay, Mrs. Rada. Other issue, please. Can I ask you about any family history of heart disease?
No, doctor. No family history.
Can you tell me about there is any change of body shape? There is any tall stature or as in your colleagues?
No, doctor.
No. Please tell me there is any chest problem before, like shortness of breathing, before than this attack of chest pain?
No, doctor. This is the first time I have this severe shortness of breath.
Okay. And you have fatigue?
I feel tired, doctor. I feel tired. I'm not as I am.
There is sweating?
A little bit.
Yes. When this?
By day or everything is normal in the last 2 days. Doctor.
Last 2 days. I mean, it's during sleeping or while daytime? Okay. And there is any weight loss?
Weight loss, no, doctor.
Or loss of appetite?
In the last 2 days, I don't want to eat anything, doctor. I'm tired.
Okay. So for that. And there is smoking?
Heavy smoker, doctor.
How many cigarettes per day?
30.
30.
Yeah.
For how long?
Since years, doctor. Maybe 10 years.
10 years. Okay. And what about alcohol?
What about alcohol? I'm not drinking.
Not drinking alcohol. Okay. Good. I need to ask you something about there is any joint pain.
Yes, doctor. I have joint pain. That's why I'm taking ibuprofen for that.
How long is for how long?
Maybe 3 or 4 years.
3 years. And
Sure.
what is yes? And what is the diagnosis of this joint pain at that time? Anyone take any advice?
I don't know. I went for my GP many times. I was living in Mexico, and I went to the doctor many times, and they gave me this ibuprofen, and they told me to use whenever I have this pain. So recently, I'm using it most of the time.
What is the joint pain affected, please?
All my joints, doctor.
Small and large joint pain. Okay. And this pain is come with stiffness or not?
Sometimes, doctor, yes.
Yes, with stiffness. Early morning.
I would say yes. Most of the time, can come in the morning. Yeah.
And for how long? Relief after this?
Maybe I'm not sure, but I think after I'm taking my breakfast and try to move, I think it's okay.
Okay. And with this ibuprofen is improving or little?
Yeah, let me say 50%.
50%. Okay. This how long this joint pain? 3 years. You see it like this when you are in Mexico, and there is any history of insect bites at that time?
Insect bite? No.
The skin rash associated with it?
No.
No, it's the skin rash. Okay. Is there any mouth sores?
Mouth sores? Yes, doctor. Sometimes, yeah, yes, doctor. I noticed also in the last 2 years, and I went to my my dentist for that, and he gave me some again in Mexico, and he gave me some creams and some gel. I'm using, sometimes helping and sometimes not. 2 minutes remaining, doctor.
Okay. And there is any difficult swallowing and tender
Difficulty swallowing? No, doctor.
tenderness muscle?
What?
Tender
Pain.
muscles. Tender muscles tender when you touch muscle.
Pain and touching the muscles? No.
Yes, please. Yes.
No.
There is red eye or dry eye?
No, my eyes is sometimes, doctor. Sometimes I have problem in my eyes.
Is it in form of what?
Sometimes redness, itching.
Okay. There's any bowel motion abnormality? Diarrhea or like this?
No, doctor.
Yes. Okay. And is there any color and urine or color and the frequency of urine changes?
No.
Okay. There's any weather intolerance?
Weather intolerance? No, doctor.
Hot or cold like this? There's any tongue pain?
Tummy pain? Not really, doctor.
Okay. There's any headache or neck stiffness?
No, doctor.
With change in vision or smelling?
Doctor, 50 seconds remaining.
Okay. What's your score, sir?
I want to know what's going on, doctor. Is it something serious? Why I have this chest pain? Am I going to die?
Okay. So from your history taking, and we need to examine you and run some investigation. From history taking, there is a problem in your chest in form of what's called maybe there is a problem in the main vessel of the aorta affected by some diseases called what's called not to confirm this, but this is what's called aortic aneurysm. So we need to confirm this about this disease, the diagnosis by confirming by.
Dying change, Dr. Fauzi. Okay, thank you very much. You feel a lot of stresses?
Yes, sure.
You felt stress, no problem. Feel the stress now better than feeling it in the exam.
Sure.
Yeah. So first of all, as usual, Dr. Please scores. Show me the scores you are going to give to Dr. Fauzi. And beside the score, write for me your differential diagnosis. Then we will start asking Dr. Fauzi questions. So scores out of 20. Scores out of 20 for Dr. Fauzi, for the doctor who joined us today. Okay, you should give the score to see. Dr. Fatima, I agree with you partially. Okay, a little bit less than that, Dr. Madonna. Okay, Dr. Shazi, I agree with the score, but don't agree with the diagnosis. Dr. Adham, correct. Okay, so I'm not saying what you wrote because I will say that after the discussion. Okay, Dr. Mina, partially agree with you. Okay, so now questions, Dr. Fauzi, what's your differential diagnosis for this case?
My differential diagnosis is a cardiac problem, or pulmonary, maybe pulmonary embolism or aortic aneurysm. But in favor of pulmonary embolism more because the desaturated, the saturation is 92, and the vein is look
92,
like
92 is desaturation, doctor.
Supposed to be above 95.
Okay. So
Okay.
what risks of pulmonary embolism did you check in this patient?
Yes, it's supposed to ask, but yes, it's supposed to be oral contraceptive pills, and also there's any clotting factors. Clotting.
Do you know if this patient has any previous admission before, any previous blood
No.
clot before?
No, not asked.
You didn't ask, right?
Yes,
Okay,
yes.
so what else could be your differential diagnosis?
Maybe MI, but here is away from the MI because
So
it's
you told the patient that you may have something in your aorta or aneurysm. Where did you get
yes,
this idea?
because tearing pain and refer to back, and this pain is continuous last 3 days and not relieved by ibuprofen or.
How would you proceed with this patient, doctor?
First of all, we'll admit here, then we'll run some investigation, emergency echo and CT autography to rule out pulmonary embolism and to rule out also the aortic aneurysm dissection.
If you will examine this patient, what are you going to examine?
The most important issue is to equality of pulsation bilateral, and also the chest auscultation and heart auscultation to rule out the pulmonary aortic regurg, and also to rule out in chest also to rule out
Did you hear about something called deep vein thrombosis?
deep vein thrombosis. Sure.
Did you ask anything about that?
No.
Don't you think you need to ask that and you need to examine that if there's a chance to examine the patient and
Yeah.
the Doppler? You know that this
Sure.
patient, if you asked about her travel history, that she travels for 6 hours going and coming because of the stresses she's suffering from, and this was 5 days ago,
No.
and she has a self swelling and pain.
Supposed to ask,
The
yes.
past history of this patient, this patient has 2 leg clots before in the last 4 years. You know that this patient has a mouth sores and genital sores.
Okay.
Okay.
Yes.
So again, now I need everyone to write his differential for this patient after this information that Dr. Fauzi didn't ask about.
Basic syndrome.
So yeah, now it's clear. Now it's pulmonary embolism with Behçet syndrome, right?
Yeah, sure.
So this case came before as it is. Okay, and again, here I will not give you a score, Dr. Fauzi. Okay, but
It's
yeah,
clear for me.
no, we will work on that. So that's why we are here. We are here to improve the missed part. So don't worry about that.
Okay,
I appreciate your being brave and practice the case, whatever it is. So don't worry about that. So the first, I will comment on your performance, the things that you need to work on. Okay, don't ask the patient why we are here today. Just tell her why we are here today. Okay, we are here today to discuss. I received a message from I received a letter from your GP saying 1, 2, 3. We are going to discuss that today. You keep repeating the questions, doctor. You
Sure.
will make the examiner crazy if you did that, because you
Okay.
wasted 50% of your time repeating the question and summarizing. You are summarizing every 2 answers together again. You can't
Sure.
do that in the real exam. You need to know how to utilize the time. You will do that in front of the mirror, okay? So you
Okay.
promise me that you are going to put the same scenario today or tomorrow, and you will stand in the front of the mirror and do the same. Try to ask the questions after we discuss what we will do. Just try to do that fast and try not to repeat, because this is one of the very difficult problem I'm suffering to change in person. The things that related to his personal way of talking. You know what I mean? I mean, it looks
Sure.
like you are used to ask the questions in details. I agree with that, but we have a limited time. If this is station 5, you will not get anything from the patient. So you spend all the time, 14 minutes, without going even to the structure of the case, and then you were lost in the middle of the case. You forget
Sure.
what you are. And this is why we are working on algorithm mnemonics. You need to have a plan. Did you read the first page of our plan? Plan approach 1 or 2. Did you read this?
Yeah, bundles. Yes.
Bundles or the other approach, whatever. They all include that you start, then you need to make analysis of the complaint, then analysis of the related symptom system, then other systems. Okay, then you will go to the structure, right? And then you ask about the impact in the life, which you didn't get. Okay, so actually we need to work in that. The other thing, this is a pain, so you need to ask what Socrates. Instead of wasting 4 minutes asking question about the pain, for the pain, just ask Socrates. Do you know Socrates?
Yeah, sure.
So simply you will ask about the site of the pain, okay, the onset of the pain, okay, the course of the pain, the radiation of the pain, okay, the association of the pain, and the exaggerating and relieving factor. Okay, then the S is the severity. So you'll ask this question, and we are done. We are done with the description of the pain. Then you'll ask him to describe the pain, the nature. Okay, then you will proceed to your differential diagnosis. You will ask about the lung, you will ask about the heart. Okay, then if any related system, then you will ask about the impact. Then you will ask the structure. Then you will summarize, and we are done. Okay, you didn't do about 70% of that. Okay, this is what we will practice on, so don't worry. Okay, the other thing, when you ask this, I'm reading my comments on your performance. When you ask about regular, try to do example on the table. So tell her, is it regular like that, or it is like? So give her examples by knocking on the table. Okay, don't tell her regular, try to do that. Okay, then you didn't show any sympathy or empathy. It's like we're talking about football game, okay? And she's dying. She has a severe chest pain. She's divorced. You didn't even tell her sorry about that she's divorced and she is in stress and she's suffering and she has a severe chest pain since 1 year and becomes super severe in the last 2 days. And you didn't tell her one sorry. I'm sorry. I'm appreciating your feelings. So sympathy and empathy, you need to work on that. This is, some drama is very important in cases. You agree with me, Dr. Fatou?
Yeah, sure, Dr.
Great. Then she told you she's smoking 30 cigarettes and you didn't give her any care about that. She has just pain and she's smoking 30 cigarettes. So you need to be surprised by the number and you need to tell her we need to work on that. Okay, actually not in this case why you didn't ask the main things, but usually you need to give an advice about this heavy smoking, right?
Sure.
Then tenderness, you can call it pain on touching the muscles. Then you can tell the patient you have aorta something. Nobody knows what it is. So if you want to say something like that, although it's wrong in this case, but if you want to say something, you have a big main blood channel in your chest. Sometimes the wall of this blood channel become very weak because of abnormality in that, because of high blood pressure. So and sometimes this wall become defective and it extend. So and cause this severe pain. This is if you want to describe something like aortic dissection, which is not our case today. But anyway,
Sure.
This is how to describe this. That you'll not tell her there's a problem with the aorta. Okay. I don't think that my mother know what is the aorta, right?
Okay.
That's it. So this is the comments. We then let's go now and I will tell you exactly what this is what I will do with this case. I will go in. I will ask about the Socrates after the introduction. I will ask about the Socrates of the pain. Then let me tell you how to describe. Okay, I will ask the patient after the Socrates to describe the pain. Okay, and I will give him examples. I'm going to ask him: is it heaviness? Okay, is it stabbing? Is it burning sensation? Okay, is it tearing? So I will give examples of the nature of the pain. This is part of the Socrates. And the other thing, I will write outside the station my differential diagnosis. Okay, my differential diagnosis is very important. Whether I have algorithm, if you remember, I say we may have algorithm, we may have a mnemonic, and it's a general symptom. So you need to go with the bundles or go with the detailed system review. You agree with me? Okay.
Sure.
So I will go and ask about in Socrates, there is association or associated symptom, and this will help me very much with my diagnosis. So I want you to remember this page, Dr. Fauzi, and every doctor by heart. When there is a chest pain, there is very important questions you need to ask very early. Some of these is associated symptom. Patient with chest pain associated with nausea and vomiting. I mean, feeling sick and throwing up, sweating, pallor, shortness of breath, palpitation, and dizziness. This is going with cardiac problem, right?
Right.
Patient with chest pain, maybe this patient has chest infection, cough, sputum. You didn't ask me even if I have cough. Okay.
Sure.
There is fever, coughing out of blood, pulmonary embolism, shortness of breath, palpitation, non-productive cough, coughing out of blood, low-grade fever, cold, muscle pain, or swelling. Then what about the gastroesophageal reflux? What if the patient has acid taste in his mouth, difficulty in swallowing, in esophageal stricture? What if there is water rash? Okay, so all these are very important questions you need to ask very early, and this will highlight for you initially what is hidden there. Am I going to the heart problem? So this is what I call the related or affected system. With chest pain, I need to remember that I need to ask detailed question about 3 systems, which are the heart, the CVS, the respiratory, and the GI, right? So if I will go classic in this case, I will ask Socrates, I will go to the associated, I start to make analysis for the symptoms. And when I have the analysis, I need to ask about the affected systems or related system, and I will ask the question from the page of the system review for these 3 systems. Then I will catch a lot of things, right? Then I will be putting there, this is, as I said, Socrates, associated symptoms, known disease, okay, past history or family history of known disease. Why this question is very early? Because they like to bring a case where any disease that is associated with mitral valve prolapse. They like it in the cases, I don't know why, but they like it. Marfan syndrome, Ehlers-Danlos, pseudoxanthoma, these 3 diseases associated with mitral valve prolapse. So ask about family history or any past history of any disease. Maybe this patient will tell you, yes, I was diagnosed by basic disease. Don't assume that the patient know that chest pain or cardiac problem is associated with chest affection or blood clot. They don't know. So just ask them. She may tell you that I was diagnosed with basic disease. You didn't ask. So now I want you to write that down. After you have this, add the letter S to the slide you received in your pre-lecture. Add the letter S and start to write what's going on there. The first thing, as I said, very important. You started by the Socrates. please, when you are in the chest pain, in the first question, the S refer to site. Okay, let the patient point toward the pain. If he points by his finger, okay, this is not a cardiac one. Usually, the patient with cardiac chest pain, he can't point to this pain by his fingers. Okay. The other thing, ask him if it is painful when he touch it or when he make pressure on it. So remember this point, please add it. Okay. Add it that you will tell the patient, can you please point to the site of the pain? Can you point by your finger to this pain? Do you have any pain when you press over it? So this is very important, and they'll tell you why, and they'll tell you the case that came 3 times in the last diet. And this question would solve the problem. Then the onset and as we said, all the spreads. Then we will write outside, as I said, our differential and try to write. I will highlight the importance, but this is for most of the things that can come for the chest pain. Just remember it, MB4 cards. You know the MB4, MP player, the MP4 player, and cards. Just remember the name. The M referred to, try to write that, you'll not receive in the post lecture. Write it, please. And again, I'm answering the doctor who asked me why you didn't write everything in the slides, because I don't want you to take the slides. I'm not a book, I am a course. So I don't want you to have the slide and read it by yourself. I want you to attend the lecture. Even if you will miss the live lecture, you need to attend the lecture and watch it, then you can fill these gaps. Otherwise, if I give you the red slides, you'll just read the slides and that's it. And you'll miss a lot of things that they didn't mention in the papers. So here the M's refer to. The first M, MI, and I mean here ischemic heart disease, but just to make it simple, write it myocardial infarction or ischemic heart disease. The second M will be for mitral valve problems or prolapse. The third M will be for myocarditis. And the fourth M will be for the malignancy and cancer, and make a big circle around this one. Okay. For Dr. Fawzi, I will close your mic, okay?
Okay, doctor.
Okay, thank you, Dr. So let me say that for the M, I will consider patient coming with chest pain. Okay, seriously, I need to exclude ischemic heart disease. This is the most serious thing that I want to exclude. So how to exclude that? Tell me in the chat box how to exclude, or not to exclude, at least what the questions I'm going to ask for a patient who have MI, for example, or a patient with ischemic heart. Write in the chat box, please. Risk factors, I agree. Okay, associated symptoms, I agree. Relation to exertion, I agree. Risk factors, Dr. Sula, this is what you mean, risk factors. Totally agree with you. Okay, so to make it simple, the 7 questions, the risk factors, the associated symptoms, as we said. So here, the associated symptoms, if the pain is associated with exertion, if there is so association with exertion, try to write associated with exertion. 7 questions for blood clotting. Risk factors, which include, we ask about smoking, we ask about high blood pressure, we ask about diabetes, we will ask about high blood level, high blood fats. Okay. So again, doctor asking about family history. Family history will be in the 7 questions. Okay, so do you remember the 7 questions? Anyone don't know what I mean when I say the 7 questions? So I will go on this patient and tell her, can you please explain this pain? What is the site of the pain? How severe it is? Where is that exactly? And is it associated with feeling sick or throwing up? Did you notice any excessive sweating with that? Do you look more pale as usual, than usual? Do you have any shortness of breath? Any awareness of heartbeat? Do you feel dizzy, or do you have any blackouts or fainting attacks? So this is the first questions I'm going to ask in the cardiac. Then I'm going to ask, is it associated with exertion? Okay, this is another association beside this. Okay, then I will go to the same question. Do you have any personal history or past history of blood clot? Do you have any family history of blood clot? Okay, do you smoke? Do you take any oral contraceptive pills? Any recreational drugs? Do you have a known cardiac problem and there isn't a problem in your heart? So this is the 4th question. Do you have any mouth sores or sores in private areas? Okay. Do you have any change in the urine color in the morning? Do you have any rash in area exposed to the sun or history of miscarriages with the joint pain? So these 7 questions, Dr. Fawzi, will solve the problem. These 7 questions will solve your problem, because as we said, any possibility of blood clot, whenever you want to exclude a disease that may be a blood clot, you need to ask the 7 questions. So these 7 questions will be about ischemic heart disease, will be about DVT, will be about pulmonary embolism. So whatever I'm going to discuss of these, okay, these 7 questions will be very important. Then the 3rd thing to ask about will be the risk factors. I want you to write it like that. This is what I'm doing in my page in front of me. Okay, I'm doing like that. Then I write here. Okay, this is myocardial infarction or ischemic heart disease. Then I'll write exertional. Okay, with this one. Okay, with association. Risk factors. I will ask 7 questions. Okay, this what I will write there. Then I will exclude it or I will confirm it. Okay, so this is very important. This is the first M. And if you did that, you will reach a lot of answers. You will reach that there is DVT. You will reach that there is basic disease. Many things you will get from this way. We will have the idea that there were a previous DVT. So in the other M, which is less frequent in the exam, but it's important, the myocarditis. And the myocarditis, I want you to write beside it. There will be a symptoms again. It could be chest pain associated with inflammatory symptoms like fever. Okay, there will be also maybe symptoms of heart failure. And remember the causes of myocarditis, and it came in the exam many times before. The causes of myocarditis, I want you to write that. Again, I'm not writing all this because it's in the box, but I want you to write this. So there is infectious causes of the myocarditis, and there is non-infectious causes. The infectious is not very important because it will not come in our exam, which is the viral. It's in the real life, it's important. The viral, like Coxsackie virus, there is Chagas disease. This is in the United States mainly. The Lyme disease, again, is in the United States. And there is toxoplasmosis in immunocompromised patients. So just remember that infections, including Coxsackie virus, can cause myocarditis. Okay, then the non-infectious, which is very important. This is more important for us. Systemic lupus can cause myocarditis. Very important. Came before in the exam. Polymyositis, because the heart is still a muscle. So polymyositis is associated with may cause myocarditis. So when you have a joint pain in this patient, the patient had joint pain, mouth sores, and chest pain, so myocarditis should be in your differential. In this case, I will mention that in my differential, but with what I have in this case, pulmonary embolism will be obvious. But anyway, here with joint pain, just to make your thoughts, joint pain, fever, mouth sores, chest pain, you need to consider systemic lupus or polymyositis or mixed connective tissue disease causing myocarditis, right? There's what's called also drug-induced myocarditis and cardiomyopathy. Remember, sometimes the drug allergy, okay, the drug allergy can cause myocarditis. The eosinophilia, the high eosinophilia that's happened with drug reaction can cause myocarditis. It didn't appear in the exam before, but this is important and it appears many times in the real life. Drug reaction can cause myocarditis and chest pain. Then there's something called giant cell myocarditis. It's very severe. It will not come in the exam because the patient's usually very sick. Okay. So remember, systemic lupus, polymyositis, drug-induced, and there is what's called myopathy. It came in the exam before. What's called postpartum, myopathy, and this coming usually in the third trimester of the patient of the pregnancy, and it can extend up to 5 to 6 months after delivery, and sometimes it's resolved and sometimes it's persistent and become very severe. And it came in the exam before. Patient with shortness of breath, lower limb swelling, chest pain, came and there's after delivery. She delivered since 3 months, and it was a case of myopathy, postpartum myopathy. So this is for the second M. The third M is very common in the exam again, not in chest pain only, but they like it in palpitation cases, heart racing cases. So remember the mitral valve prolapse, and they like that the association of the mitral valve prolapse with the other connective tissue diseases, like in Marfan syndrome. You can't ask the patient that did you notice total stature, just notice him if he is very tall. Then ask him about hyper. We will discuss the Marfan syndrome, and you have it on YouTube, the total stature lecture on YouTube. Whenever you have time, watch it. But I want you to remember that you need to ask about the hyperlaxity of the joints. We'll go through that, but the hyperlaxity of the joints, with history of palpitation, patient with Marfan will have pneumothorax, joints pain, bleeding. We will go through these diseases in through our rheumatology. So mitral valve collapse and it is association with Ehlers-Danlos and Marfan. Then and so soma elasticum, and I will tell you what the difference between them later on. Then the fourth M is malignancy, and this is the case that came in the last night. Malignancy. I have 2 candidates who get a full mark in this case because they did the case perfectly. They went through all the details of the chest pain. They excluded everything. The patient came with previous history of cancer that treated, and it was the patient was cleared from cancer since 6 years ago or 5 years ago. And he's coming now with the chest pain. And the candidates they went through the description of the pain, the associated symptom. They exclude the cardiac, they exclude the respiratory causes, and they exclude the GI GERD symptoms. And when he gave them the history of the cancer, and the nature of the pain and the tenderness and severe tenderness in the pain they felt, they considered if anyone who said, and the patient concern was, is it a heart problem? Is it related to cancer? And some of them said no. And the patient really, this was a metastasis case. It was a metastasis case, and if anyone only said metastasis without excluding these, it's a big problem, and they got a very bad mark. In this case, who came in UK 3 times, this died. And anyone who gave the possibility, I'm sorry to tell you, and there were some other symptoms like low-grade fever, and the patient started to develop some symptoms, like warning symptoms. So you should consider the presence of metastasis and invasion of the pain. So that malignancy and whatever, can be lung malignancy, it can be bone, it can be mixed to the chest wall. So all these should be considered in the chest pain. So remember, the fourth thing is malignancy. That's why if you just follow the mnemonic, you remember how to ask. You can catch most of the things that can be hidden in the exam, and you can get the full mark. So I have 2 candidates that get 20 over 20 in this case, and 1 candidate gets 6 over 20 because he gave them a differential. He told the patient, no, it's not related to cancer. He told them definitely it's not related to cancer, and it can be. We need to check, and he gave them a very vague answers, and he didn't include even the possibility of cancer in them. They tell him costochondritis and musculoskeletal, but he didn't mention the relation to the cancer. That's why his management plan was very benign with a patient that's very advanced disease. So these are the M's. Give me the okay with the M's now till we move to the P. Are you okay with the M's? So MI and stem heart disease, myocarditis, mitral valve prolapse, and malignancy. Don't feel that it's a big amount of information. We will go through everything. So at least I want you after this part to be sure that when you have a chest pain, you will not worry about. Then the P is referred to the first P for pulmonary embolism, right? The first P is pulmonary embolism. And here you need to, again, with the symptoms, you will ask shortness of breath, palpitation, non-productive cough, coughing out of blood, low-grade fever, lower limb swelling, muscle pain. So all the details of pulmonary embolism will be here, but you need to ask, which is very important, to ask about the risk factors of pulmonary embolism. This is very important. So please write. The first thing is the 7 questions of blood clotting. Again, it is a blood clot. So the 7, you will not ask them again. I mean, remember that this should be asked. If you missed it in the M's, you need to ask it in the P's. So the 7 questions, blood clotting, and with the associated symptoms, you already asked it, so it guide you toward the pulmonary embolism. Then you will ask about the risk factors of the DVT, of the pulmonary embolism. Like what? What are these risk factors? Traveling? Traveling, very important. Recent surgery. Prolonged recumbency. Oral contraceptive pills, you asked it already. Prolonged immobilization, yes. Long flight, delivery, I agree. Immobility, I agree. But I mean, oral contraceptive pills and smoking, you already asked it in the 7 questions. So these questions are very important. Traveling. What about the job? What if the patient is driver? You think this make a difference? It's important, right? So the job of the patient is very important. Here, you need to ask the social is very important in any case, but the job in this case and the lower limb swelling, the calf muscle swelling, and pain and tenderness is super important. And beside also the 7 question, which include the previous history of blood clotting, right? So this is very important. Then the pericarditis, the second piece of pulmonary embolism. Again, you will ask these very early, the symptoms of pulmonary embolism, and you will ask the risk factors. I want you to ask beside the 7 questions for sure. What about the pericarditis? Recent infection, right? It decreased by leaning forward, so the patient will be leaning forward all the time because this relieves the pain. Then other thing, history of some diseases that it was enterocolitis. So patient with systemic lupus, patient with FMF, as we said the last time, they may have chest pain because of that. So remember, you will ask about recent infection. You will ask about the nature of the pain if improved with leaning forward. You will ask about joint pain, mouth sores. You will ask about fevers. You will ask about tummy pain. So you will ask about joint pain, stiffness for the disease associated with psoriasis. So again, don't become confused. These are the things that you write outside. You write the MB4 cards outside. Then when you are inside, at the stage of analysis of the differential diagnosis, you will go through every one of these. So if you remember approach 2, you will go, as I said, introduction. Then analysis of the complaint. Then analysis of the related system, and that's it, cardiac, the respiratory, GERD, and this stuff. Then in the analysis of the differential diagnosis. So this is my differential diagnosis. I'm going to ask about everyone. Then if I have time, I will go further to some systemic review. Then I will summarize. Then I will do, the structure. Then I will summarize. Then that's it, the concern. So that's why you need to be fast. You need to practice it fast. Then the third P is the pneumothorax. What will you ask about pneumothorax? Chest pain, history of flights, previous pneumothorax. And again, the patient like Marfan's and Ehlers-Danlos and these patients, they may have again the risk of pneumothorax. So previous pneumothorax, the patient was thin with tall stature, they can have a pneumothorax. So previous attacks, flights, and something like Marfan syndrome. Then the last P is pleurisy. So the patient will, if the patient has a history of chest infection, again the systemic lupus and this stuff, Systemic lupus and FMF and chest infection, they cause pleurisy. And remember, with pleurisy, there will be fever, there will be shortness of breath. And don't ask me how I will confirm it is pleurisy. Again, for any chest pain, it's not about pleurisy, it's about the other things that you are going to exclude. So if you didn't exclude, okay, the other important thing, even if you reach the correct diagnosis, you didn't do your job. You need to exclude, and the examiner wants to see that you know what is the differentials for the chest pain. Then the C go to costochondritis, and remember, this is tenderness. There will be difficulty with breathing, the pain increases with breathing, and there is a tenderness. So this is the C, costochondritis. The A refer to aortic dissection and aortic stenosis. For aortic dissection, there may be a history of, again, diseases like the Ehlers-Danlos hyperlaxity, previous bleeding. Okay, there will be severe pain radiating to the back. There will be history of hypertension. So the pain will be acute, referring to the back. There may be history of vasculitis or history of collagen disease. Then aortic stenosis, and it is, again, it's uncommon to have this severe case, aortic dissection that could come in the exam. Could be super acute, but still you need to exclude it. Aortic stenosis, the patient will have history of syncope, shortness of breath, so you need to consider it. It would be a new differential if the case came out cardiac. Then the R referred to reflux. Reflux, okay? Gastroesophageal reflux. Very important. You will ask the patient about relation to meals. You will ask the patient if this is increasing after meal, decreasing after meal, or whatever. Okay, if there is morning acid taste, if there is coughing in the morning, there's difficulty in swallowing. And the other R for respiratory tract infection. Patient with chest pain because he has respiratory tract infection. What's the problem? Again, don't ask me how to do that. You need to exclude everything else in the presence of fever, coughs, sputum, and this stuff could be respiratory tract infection. And maybe eventually in the exam you'll find a case of immunocompromisation or something like a hypogammaglobulinemia. So they are looking. Sometimes they bring infection, and behind that they found anything that's related to immunocompromisation, HIV with recurrent respiratory tract infection, for example. So when it is infection, there could be something hidden behind it. Then the D's refer to drugs. What drugs can do chest pain? Write in the chat box, please. What drugs or medications can cause chest pain itself? Write in the chat box. Cocaine, perfect. Cocaine is very important. Amphetamines, perfect. What else? Ecstasy. Okay. Triptans, perfect. Triptan, I agree. For migraines. Okay. Ergot, I agree partially. What about sildenafil? Can sildenafil cause chest pain? Viagra. Can it cause chest pain? Yes. It can cause chest pain. The sildenafil and the Viagra, yes. The Viagra, the sildenafil can cause chest pain and blue vision. Remember, blue vision and chest pain. Beside, it's important as side effects. So the S, the last is referred to, this S, referred to skin. I want you to remember the herpes zoster. Herpes zoster. So skin disorder, herpes zoster. The patient coming with chest pain, electrical chest pain with rash. When you look with the rash, it is a vesicles coming through the nerve dermatomes, coming below the armpit, taking part of the chest. It's not classical all the time, but start by severe chest pain, and then the skin symptoms can start, or the skin signs can start. So ask the patient if you have rash, if there's a rash, burning sensation of the skin of the chest. Why I add this? Because it came once. They have acute case in their ward, so they bring the case. They just brought the case in UK, and they all they try to do everything. Okay, it was station 5, and when some of them start to examine the patient, once they see the rash, they know that it is herpes zoster. It's very difficult to know or ask if you didn't see it. Some candidates, unfortunately, they just see that and they just ignore it. And the examiner asked them, "Did you notice anything abnormal in the chest?" They didn't even mention the rash. Okay, and the patient was putting cream over it. You know, they were creams. He put some cream, some topical medication over it. It's local anesthesia. And some candidate didn't. That's why you need to comment on everything you see on the patient's station 5, because you can see rash with cream over it on the chest, and you didn't even comment on that. Okay. Then you will finalize based on your differential diagnosis. Then you ask about the impact of this chest pain of the patient. You will go through the social, the past history. Okay, if you have any history of blood clot, any history of high blood pressure, diabetes, family history, sudden cardiac death. Okay, anything of these. This is the past history. Then you will go to menstrual history for this patient. You will discover that she's taking oral contraceptive pills and she is sexually not active. You ask about traveling history and the patient travel. Their friends took her to travel for, I don't know, for Indonesia. Okay, for 1 week to relieve her stresses. Okay, so this is the travel history. Medication history, she is in ibuprofen and again oral contraceptive pills. Okay, so if you forget all that, you'll miss a lot of things that in social history. What is the job of the patient? She is a driver and she's spending 6 hours sitting every day. So this is another risk factor. For example, okay, smoking history, she's smoking 30 cigarettes a day. This is super important. She's divorced and she's under a lot of stresses. You can advise her, give her an idea about the social workers that can help her, support her, not in order not to kill herself, for example. Okay, and to quit smoking when smoking cessation clinic. Okay, then you will ask the concern, then you will give her the management plan, then you will finish, then you will get the full mark. This is how to do this type of cases. I spent 1 hour in this case because it is important, and the chest pain is very commonly tested in the exam. So I want you to be very confident. Without practicing yourself, without do a case or 2 or 3 with your friends, okay, you will not be able to do that. My advice: when you hear the things from me, it looks simple. When you do it, you will miss a lot of things. So please try to do it yourself. If you have any one to practice, this is the only one I allow you to share with the pages. So don't share, as I told you, it is Amana. Don't share our page, our slides with anyone outside the course. It is Amana, okay, in your name for everyone. But if you have someone who's working with you and you want to practice with him, so just print this page and go and let him pick in his mind one diagnosis. He will put a diagnosis in his mind and start to answer your question. So try your fluency and sequence of questions you are asking, okay? And keep asking. You will miss the GERD. You will miss many diagnoses. Then eventually you'll be very confident when you have a chest pain. If you have this differential in your mind, even in your daily practice, it will help you not to miss any cause of the most common cause of the chest pain, okay? Including lung cancer, including pericarditis, including myocarditis, whatever what we discussed in this case, okay? So yes, it can come with the chest pain. Doctor asking me, can't aortic valve? We said the A is aortic stenosis, okay? Aortic regurg, it can be aortic dissection, as I said. So aortic disease is the A, okay? The arrhythmia can be part here. The arrhythmia, that's why we are asking about irregular heartbeat. So we're asking about the irregularity, the palpitation very early when you are considering. The patient described the irregular heartbeat by palpitation. Okay, so if there is arrhythmia, any cardiac can associate with arrhythmia, and the patient will describe that with palpitation or heart racing. And when he describes the heart racing, you will not show him that this is the regular or irregular. Okay. But remember, they don't like to, they will not bring a case of aortic regurg, for example, in station 2, and even in station 5 it can come, but because this case can come in the station 3 of the cardiology, so it can come in station 3. Okay, so they will prefer to bring it in station 3 if they have a case of aortic regurg, because there will be a lot of finding you need to examine in details. Okay, so usually this is the case. Pulmonary embolism, they are hiding, and it is not enough. Pulmonary embolism only, you will get about 12 in this case. Pulmonary embolism with basic disease, you'll do the full mark. So remember the circles. Do you remember the colorful page? Do you remember the colorful page? You need to search for the etiology, the cause. So this pulmonary embolism, the association. So you will catch the basic disease there. Okay. So give me the okay in the chat box that you're okay with the chest pain now. Give me the okay. Do you feel it's better now? You feel more confident to go through a case of chest pain? Okay, great. This is what I mean when I say there is a plan. When you have a plan. Thank you, Dr. Madonna. Thank you, every doctor answering. So this is when you have a plan, you will not be missed. Once you see chest pain outside, you will not be worried. You know what you're going to do. Okay. Good. So let's go to the next case. Can you please give me 2 minutes? 2 minutes, and I'll come back to you. And instead of wasting the 2 minutes, I will give the case to the next doctor. Then I will take the 2 minutes till he prepare himself. Okay. So we will take for this case. Let me see. Okay, Dr. Fatima, because you missed your turn last time. Dr. Fatima, are you there? Dr. Fatima. So the one who will take this case is usually lucky because he will just follow what we just described, what we just discussed. Sorry. So Dr. Fatima, I'm opening your mic. How are you?
Yes. Yes, I'm good, Doctor. I'm good. Yes, I'm good.
Are you okay with the chest pain?
Yes, I'm good.
Okay, good. So I will give you now the scenario. Then we'll take 3 minutes to come back.
Okay, sure.
This is Mr. Boris. I will clear this. This is Mr. Boris Daniel. So you have 3 minutes. So there is a doctor asking, anyone want to pray? Anyone want 3 minutes or 4 minutes to pray? Tell me in the chat box. Okay, so most of the doctor asking for 5 minutes to pray. So okay, it's 5 minutes. Who want to pray? Pray. Who have no pray? Prepare yourself for the case. Okay.
Okay, sure.
You have 5 minutes from now.
Yes, thank you so much.
Okay, hello. So 1 minute more and we can continue. 1 minute more. Okay, can you start, Dr. Abatna? Your mic is closed or what? This mic was closed.
Yes, Dr. Daniel.
Yes, Dr. Howard. Can you just start the timer?
Can I start now?
Just a second. Start the timer. Okay, start it.
Hi, this is Mr. Boris Daniel.
Yes,
Hello, I'm Dr. Fatima, one of the doctors in the medical admission unit today. How are you doing, Mr. Davis?
I'm okay, doctor.
Okay, sorry, I'm sorry to call you by the wrong name. So, Mr. Daniel, how are you doing today?
I'm good.
Okay, so Mr. Daniel, we are here to discuss about your health. So I got a letter from your GP saying that you are having some chest pain. Is that right?
Yes, doctor.
Can you tell more about your chest pain, Mr. Daniel?
Yes, doctor. I have this chest pain, which is in the last 4 months.
Mhm.
And actually, this pain, I'm very worried about this pain because, I think my doctor told you that I have a problem in my heart. And for this problem in my heart, I had some angio. They make me some procedure and they put some stents. And when I start to have this pain, which is in my chest, so I start to worry again if the stent is not working well or if I have a new problem in my heart. That's it. That's why I'm here today. My GP tried to increase the dose of the medicine, and I feel that it's worsening the condition more than helping.
Okay, I'm so sorry to hear about your suffering, Mr. Daniel. I'll try to do my best to help you in this regard. So, Mr. Daniel, can you show me where you have the pain exactly, the site of your pain?
Yeah, it is. The patient is pointing toward the epigastrium and retrosternal, and he's pointing by his fingers, by his 5 fingers.
Okay, Mr. Daniel, can you tell me how your pain started?
I'm not sure, doctor, but I know that in the last 4 months I start to feel this chest pain.
Can you describe your pain? Like, is it gripping type? Is it burning type of pain? Is it twisting type? How can you describe your pain for me?
You know what? I would say, doctor, it's like burning.
Okay.
Yeah.
Okay, I'm so sorry to hear about this. So, is there any relationship to your food that you take?
I would say yes. It's a little bit worse after meals.
Okay, I'm so sorry to hear this again. Can you tell me how severe your pain is on a scale of 1 to 10, with 1 being
Yeah,
really...
sometimes, doctor, it's severe up to 6 or 7, I think, and sometimes it's just agonizing me.
Okay. Is there anything that makes your pain better?
I tried for some days to do less effort. I'm trying not to eat a big amount of fats because I think it can affect my heart. And I think there is some improvement with that.
Okay. Good to know that something is helping you. Is there anything that makes your pain worse?
I would say again, when I eat something full of fat.
Okay. I'm so sorry to hear about your pain. Does your pain go anywhere else, or is it just in your upper tummy?
I felt it in my throat, doctor. I feel it in my throat also. It's in my chest and I feel it in my throat.
Okay. But do you have a change in taste of your mouth? Like, do you have any metallic?
Yeah, sometimes. Yeah, sometimes in the morning I feel that there is an acid feeling in my throat, and I have
Okay.
Yeah.
Okay, Mr. Daniel. Is there like your pain? Is there anything else associated apart from your pain? Like, do you have any nausea, vomiting?
You mean feeling sick?
Yeah, do you feel sick?
Yes, doctor. Yes, I'm feeling sick many times, and I remember when I had the heart problem before, I felt sick also at that time, and I threw up twice. So sometimes I have this feeling, and I become very scared when that happens.
Okay, I'm so sorry to hear about this. So you've thrown up only 2 times, and when was the last time you threw up?
Yes, I threw up also this time. I threw up in the last 4 weeks. I threw up about 3 times. I threw up 3 times. Yeah.
Okay, what did you throw up, Mr. Daniel? Was it blood or was it just the food that you had eaten?
No, it was food.
It was food. Okay. And can you tell me the color of the? I mean,
It was just mixed with food, doctor. It was the food that I had pain. Then I threw up and I felt better.
Okay. Okay, Mr. Daniel, I'll try to do my best to help you feel better. Daniel, have you noticed any other symptoms like any loss of weight in the recent time?
Yeah, loss of weight, no. Doctor.
No. Okay. Any increase or any decrease in your food intake?
You mean the food? Yeah, I think my appetite. You mean?
Yes,
My
appetite.
appetite is a little bit less than before.
Okay. And have you noticed any weight change along with this?
Weight change? I lost some weight, doctor.
Okay. Can you tell me exactly how much you lost, Mr. Daniel?
I would say in the last 1 year, I lost about 7 kilograms.
Okay, I'm so sorry to hear about this. I'll try to help you to the best of my ability. So you told me last time, have you noticed any pallor or salving of your skin?
Well, a little bit. My wife told me that my lips look more pale than usual.
Okay. And have you noticed any change in your bowel habits? I mean, change in your bowel habits? Like,
Yeah, I think, sometimes I have lost motion.
you have loose motion. Okay. Any constipation?
What?
Do you have any constipation? Like, you have difficulty to pass stool?
No, hard stool, no.
Only hearts. Okay. You have any loose motion. And what's the color of your loose motion?
I noticed, doctor, sometimes it's black.
Okay. I'm so sorry to hear about this. Okay. Mr. Daniel, I'd like to ask a few questions about your past history. Is that okay with you?
Yes, doctor, sure.
Okay. So, Mr. Daniel, have you had any other, apart from the problem regarding your heart and your surgery, have you had any other chronic medical history in the past?
Not really, doctor. I would say that I had the joint pain, osteoarthritis in my knee, for which I was taking some painkillers, okay, naproxen. Okay, I'm taking over the counter for my knees. Otherwise, I'm just taking the medicine that's written by the heart doctor.
Okay. Can you show me the medication list?
Yes, I'm taking aspirin 75, I'm taking losartan 80 milligrams, atenolol 50 milligrams, and simvastatin 80 milligrams.
Okay. And plus you're taking your diclofenac, you said, I mean, naproxen, you said, right?
Yes, I'm taking naproxen, yeah. When I have the knee pain, I'm taking naproxen.
Okay. Okay, Mr. Daniel. So apart from the joint pain, do you have anything else? Any past surgery?
No, only this cardiac problem.
Okay. Anything in the family that you want me to know? Any similar history or anything else you'd like me to know?
In myself, nothing extra this year. I have
Family history. Any family history?
history? Yes, doctor. I have my uncle who died with problem. He has some tumor in his bowel, but I can't remember what was that. But he was young at that age. He was 45.
I'm so sorry to hear about this, Mr. Daniel. So he had some cancer, you said, or some problem?
Yes, some cancer.
Some cancer. Okay. And 5 years, right?
He was 45 years old when he died by this problem in his bowels, or his, I can't remember exactly which part, but it was part of his bowel system.
Okay. Mr. Daniel, I'd like to ask you 2 more questions regarding your personal life. So, whom do you live with, Mr. Daniel?
With whom I'm living with my wife.
Okay. Is your health affecting your personal life in general?
Sure, doctor, sure. This pain will start. I'm very worried about my wife. She's suffering from rheumatoid arthritis, and I'm taking care of her. So I'm very worried if something happened to me, that she will be alone.
Okay. I'm so sorry to hear about this, Mr. Daniel. I'll try to refer you to our, so I will try to, look into the matter and we'll try to make sure that you're, worked up well, and we'll also refer you to a social worker who can help you with any financial matters or, any personal concerns that you're having. So what do you do, Mr. Daniel?
I'm truck driver, doctor.
Okay. And is it affecting your work? Is your problem affecting your work?
Yes, doctor. I'm very worried to have some heart attack while driving, so I would kill myself.
Yeah, I'm so sorry to hear about this again. Mr. Daniel, I just would like to tell you that, I would, advise you. Yes. Mr. Daniel, I was saying that I would advise you to stop driving until we run the investigation and get the results in our hand to confirm what the diagnosis is. It may be dangerous for you to drive for now, okay? And I'll refer you to those occupational health services at the hospital who can help you with an alternative job or whatever help they can help you with.